Good morning, good afternoon, good evening, everybody, wherever you're joining us from. Welcome to Gulf Amyloidosis Club. Welcome to the second session of this exciting event that aims to bring to you recent advances in the diagnosis and treatment of cardiac amyloidosis. My name is Firas Al-Badareen. I'm a cardiologist from Cleveland Clinic, Abu Dhabi, and I am the head of the imaging working group of Emirates Cardiac Society. I would like to thank our presenters in the last session and our presenters in this session. I would also like to thank our participants for dedicating their time to join us in these educational sessions. Lastly, I would like to thank our sponsors whose generous support made this event and similar events possible with their generous support. Before we start, we'll take a few minutes to watch a video to bring everybody up to speed about the diagnosis of cardiac amyloidosis.
Deciphering ATTR, transthyretin amyloidosis. Transthyretin amyloidosis, or ATTR, is a systemic, progressive, and life-threatening condition that affects many of the body's organs and tissues. ATTR can manifest clinically with a cardiac-dominant presentation or with a polyneuropathy-dominant presentation. Mixed phenotypes of both are present in many patients. ATTR can progress rapidly and prognosis is poor, making early diagnosis and treatment critical. Median survival for patients is 5 to 15 years from diagnosis for those with polyneuropathy and only 2 to 6 years from diagnosis for those with cardiac involvement. Transthyretin, a plasma protein synthesized in the liver, normally circulates in a stable form made up of molecules called tetramer. In ATTR, this tetramer becomes unstable and separates into individual monomers, which then fold, aggregate, and form amyloid fibrils that accumulate in multiple organ systems, leading to eventual organ failure and death. Deposition of amyloid fibrils in the nervous system leads to peripheral and organoid neuropathy. Amyloid deposition in cardiac tissue leads to hypertrophy, stiffness, dysfunction, and cardiotoxicity. Patient presentation is often mixed with both cardiomyopathy and polyneuropathy. Multiple other organs and systems are often affected. Two classifications of ATTR are recognized: an autosomal dominant hereditary form and wild-type ATTR, which is not associated with a gene mutation and develops spontaneously with aging. Once considered rare, ATTR is now understood to be under-recognized and misdiagnosed, and is a condition that should be screened for routinely whenever there is a high level of suspicion. Disease course and symptoms. Multi-system involvement and highly varied clinical presentation can make identification and management of ATTR difficult. Polyneuropathy drives many of the most debilitating symptoms in patients with ATTR and results in especially severe patient burden and functional impairment. Amyloid infiltration into the nerves commonly presents as pain, which can often be severe, numbness and paresthesia in the feet, and progressive sensory loss affecting the legs, hands, and arms. Muscles weaken as the disease progresses, and patients experience walking difficulty with gait and balance abnormalities. Autonomic dysfunction, present in up to 75% of patients with ATTR polyneuropathy, and manifests as orthostatic hypertension, current urinary tract infection, sexual dysfunction, gastrointestinal disturbances, and weight loss. Amyloid deposition in the heart results in restrictive cardiomyopathy, accompanied by increased left ventricular mass, leading to heart failure punctuated by conduction and rhythm disturbances. As heart failure worsens, patients experience a rapid decline in functional capacity, including fatigue, shortness of breath, and reduced exercise capacity over time that affects their ability to perform everyday activities. Diagnosis. Early diagnosis and treatment of ATTR is critical due to the progressive nature of the disease, yet it is usually delayed for years due to lack of awareness, frequent misdiagnosis, and symptoms that mimic other conditions. ATTR cardiomyopathy has been increasingly identified as an underdiagnosed cause of heart failure and may account for up to 10% of heart failure cases in the elderly, 13 to 17% of heart failure cases with preserved ejection fraction, and 1 in 6 patients over 65 referred for transcatheter aortic valve replacement. ATTR cardiomyopathy should be strongly considered in patients with heart failure or unexplained neuropathy, and especially those with a family history of amyloidosis or unexplained left ventricular wall thickness. ATTR should be considered in patients with progressive axonal polyneuropathy or atypical CIDP, especially when accompanied by autonomic dysfunction, early gait disorders, spinal stenosis, gastrointestinal disturbances, and weight loss, carpal tunnel syndrome, or previous surgery for bilateral carpal tunnel and concurrent cardiac abnormalities. Additionally, diagnosis is obtained through tissue biopsy, but can be made non-invasively with bone scintigraphy imaging. While biopsy can be performed to identify suspected ATTR, finding amyloid deposits can be challenging, and negative results should not exclude an ATTR diagnosis. When ATTR is strongly suspected or confirmed, TTR gene sequencing to determine the presence of a pathogenic ATTR genetic variant is recommended for prognostic and family screening purposes. Disease management. Understanding the causes of ATTR and disease progression has led to the development of therapies that intervene in the pathogenic amyloid cycle in ATTR. As transthyretin is primarily produced in the liver, one approach is to reduce the production of TTR protein levels in the liver through silencing the gene with antisense oligonucleotides or small interfering RNA. Another approach is to enhance the tetramer stability, thereby preventing the TTR protein from dissociating into monomers that can form amyloid fibrils. Because of the multi-systemic nature of the disease and often severe symptom burden, comprehensive disease management is required to address cardiac sensory motor and autonomic symptoms. Today, action is needed. We must increase awareness of ATTR, improve diagnostic practices, and develop new treatments that can lead to better outcomes and quality of life for patients with this complex disease.
All right. We apologize. I realized the quality of the voice was suboptimal, but I hope you found that little video educational. So let's kick off our session for tonight. Tonight we have two amyloid experts from Saudi Arabia and from the United States. Each of them will talk to us about recent updates on the imaging of cardiac amyloidosis. I'll start with my friend and colleague, Dr. Dania Moti from King Faisal Center, where she leads the amyloidosis program. We've worked on different regional and local projects together. And Dr. Moti tonight will update us about a recent article using echocardiography to differentiate AL from ATTR cardiomyopathy. Dania, the floor is yours.
Good evening. Assalamu alaikum, everyone. Good evening, everyone. Thank you so much, Dr. Firas, for the kind invitation. I'm very delighted and honored to be part of this event. And without further delay, I have no disclosure regarding this representation, and then I will share my screen. I hope it will work this time. Are you hearing my voice? Okay.
We hear you well, yeah.
Yeah, okay. So yeah, I thought when you asked me this to present this article, just let me put it on full diaporama. Okay, so can you see it now? Perfect. So basically, this article is very nice coming from the teams of Patricia Pelica in Mayo Clinic, where I work as a fellow for 2 years. It was a very nice experience 20 years ago. And it actually just released last week. I was receiving some PubMed articles. When I called me, I received it just the same day. So I said, why don't we work on it? Especially it is really hot topic, and it's very important for the patient to differentiate between when it comes to patient, it comes to the clinic, to make the difference, the clear difference between ATTR cardiomyopathy phenotype and light chain phenotype, and especially that we have many mistakes on the clinical practice, actually, unfortunately for the patient, where he was taken as ATTR and it was basically light chain, which we know it's an urgent disease to diagnose and to treat. So I know that you told me don't go further into details because people knows exactly what's ATTR and what's light chain, but just remind maybe the youngers or the resident, if they are connected, to see that we have more than 40 precursors protein capable of forming amyloid fibrils in vivo. However, in our clinical practice, I want you to remember that 98% of the amyloid heart disease will be due either to light chain or to ATTR types. From the ATTR, we will meet most of the time the wild type one in our clinical as as a cardiologist, or acquired disease, which is due to mutation of the gene on the ATTR gene on the chromosome 19, which is dominant mutation. And the phenotype could be different according to the mutation and the country and the place where we are living. So both of them leads to the position of either mutated transthyretin or wild type transthyretin on the organs, and which lead eventually to organ damage. From the other side, we have this light chain amyloidosis due to deposition of abnormal light chain Ig due to plasma dyscrasia. And of course, we have all the other type of amyloids that are very rare, but yet some of them will lead to cardiac involvement. Some of them are not lead to that. So just to remind you here, we have an underlying plasma dyscrasia that is completely abnormal plasmocytes that leads to excess production for some reason under unknown causes, becomes completely abnormal and start producing free light chain with an excess of unstable free light chain. And this free light chain that are completely pathological will misfold, allowing to the exposure of hidden epitope, which allow aggregation into prefibrillar aggregate. And then they have direct tissue toxicity, mainly affecting the heart. And that's why on this type of disease, most of the time we have less hypertrophy and more rather toxicity, direct toxicity of the light chain that suffocate the myocyte. And of course, we have the other involvement that are the kidney in 70% of the case. Most of the time, kidney and heart goes together. You have this soft tissue involvement, this purpura, or the signature of the disease itself. So we have organ damage almost everywhere for this disease, and it's really urgent. And I made this just slide to show you really that light chain is an acute disease and need to be treated and managed and diagnosed very fast, less than 2 to 3 weeks. And ATTR is kind of chronic disease. It's not less fatal, but it's more chronic, and we give ourselves a few more weeks to make the diagnosis. It's the survival is 4 to 6 months or so. Now we have better data, of course, if it's untreated, especially the staging Mayo Clinic staging 3B. And on the other side, the chronic one, we have 4 to 6 years survival if it's untreated. So just remember, it's less urgent. This is 4 to 6 months. This is 4 to 6 years for the eye, just remembering that both diseases are different. Regarding the echo data, because the article I chose deal with articles, just to remind you that echo in cardiac amyloidosis is the cornerstone, and it's abnormal in 93% of the case, especially when the patient comes to mid-stage, where we diagnose the patient, not on the early stage. And we have basically, it's a blind disease and it goes everywhere. The fibrils goes everywhere, whether ATTR or light chain. They are hidden on the septum level, on the atrial septum level, on the valves levels. So we have symmetrical thickening of the LV walls. Also, some patients would have maybe basal septal bulge when they have hypertension before, or aortic stenosis. We have dilated atria because of the atrial myopathy and also because of the raising feeling pressure. We have small pericardial effusion, and we'll talk about it later. We have mainly on this disease comparing to other cardiomyopathies such as Fabry or HOCM, a severe destruction of the longitudinal function, especially revealed by the MAPC that is destructed, the S prime on the mitral level, annular, septal or lateral, and also, of course, decrease of the global longitudinal strain. It depends on the level of the discovery of the disease, but we have not only reduced GLS much earlier than the decrease of the ejection fraction, but also we have this kind of pattern that we call cherry on the top, or relative apical sparing, where we have relative preservation of the apical segment comparing to the basal to the mid, which have high sensitivity, and we're working on this meta-analysis to see exactly what is the exact accuracy of these parameters. And of course, because of this infiltration, we have alteration of the hemodynamic parameters, such as feeling pressure on the left side and the right side. And you can see also pulmonary hypertension, RV dysfunction, and all the other alteration of any diastolic dysfunction and later on systolic dysfunction. So putting this in mind, just to show you by images, and I like to show, like in one slide, what are the damage due to the cardiac ATTR involvement and versus the light chain. You can see that both of the disease have both patients have cardiac amyloidosis. However, one of them has been having ATTR cardiomyopathy for the last 4 years, and you can see the thickness, the level of the thickness, and the importance of the thickness of the LV. While on the light chain, this damage developed over only few months, and you can see the LV is not really severely hypertrophied or thickened, but the longitudinal function is really destructed. Also, the ejection fraction could be more or less mildly reduced, around 45%. We'll talk later about this pattern of the GLS in both articles, because there has been difference between the previous articles and now. Now, just to show you again what I told you, if you delay the diagnosis of light chain by 2 weeks, this is from Dr. Stefano Perlini slide, showing that if you delay less than 6 weeks, the prognosis will significantly be affected if you take time to suspect or to diagnose light chain amyloidosis. So as soon as you think of it, please go and do the free light chain, do the immunofixation, and do the tissue biopsy, and try to diagnose the patient as soon as possible. Just to show you that has been, because again, we'll talk in the article about it, the biomarker have major prognostic importance to predictive survival. And this is the most recent Mayo Clinic staging, taking in account the proBNP, the troponin, and the free light chain level. And the article will show you that maybe this prognostic staging, also it is still using now. We can maybe add some echo parameters of this one. And the more you have abnormal parameter, the more the survival will be affected. The same prognostic staging has been done also for the ATTR from the NAC, the National Center of Amyloidosis in London, taking in account the biomarkers of the anti-proBNP and the GFR, the kidney, and the more the parameter are affected, both of them, the more the prognostic is affected. Now, just to show you, when I saw the article last week, I told you with Dr. Firas, it reminds me immediately the article that has been done 10 years ago in 2014 by Dr. Rapezzi, showing you exactly the difference between the different phenotype by echo phenotype and the relation to survival, mainly almost the same design. But actually, the difference is what only they, at that point, 10 years ago, 172 patients were a lot, and now we're diagnosing more and more. And the main difference is the number of the patient, the large cohort that Mayo Clinic has, more than 1,000 comparing to this one. But basically, these articles, you can see they compare 3 of them, the wild type, the hereditary one, and the light chain, but only 172 patients only, but also it's a big series. And basically what I have been shown, and you will discuss it comparing to this now, that the wall were thicker in the wild type, just like I showed you, because of the longer chronicity of the disease than other type of the cardiac amyloidosis. Ejection fraction remains preserved in both, but lower in wild type ATTR. Stroke volume and cardiac output lower in the wild type ATTR. RV free wall thicker in the wild type. PA pressure equally high in all type of amyloidosis in advanced stage. Diastolic pattern not significantly different between light chain and ATTR, and pericardial effusion were present in all type in these articles, and we'll see it was different on that one. So being having said that in mind, the background of the article, the one I want to present now, is that amyloidosis is more common than previously recognized. We have different presentation, clinical courses, and different prognosis, and this has been acknowledged by the authors. And the early diagnosis is crucial for the treatment selection and the early recognition of the difference. So the knowledge gap, according to them, that are limited data on the echocardiographic difference between types. Current staging systems don't include cardiac imaging, and we need to identify prognostic echo markers at diagnosis. And what is new about this paper is that we thought that GLS could be part of this prognostic staging, the global strain and the apical pattern, and here they are showing different things. So the objective of this current articles is to using a very large cohort to determine the distinct echocardiographic feature of each type of amyloidosis, whether wild type ATTR or hereditary versus light chain, and to evaluate the independent prognostic significance of these features. It is multi-campus retrospective cohort from 2010 to 2020. They took almost 2,000 patients with confirmed amyloidosis, which is huge. I think the highest series in addition to the French one with Thibaut Damy, my colleague in Paris. The mean age was 67.5 years, plus minus 11 years. The gender was 75% of were male. They took all the patients from Minnesota campus, Arizona, and Florida, and the median follow-up was 24 months. They confirmed the diagnosis as per guidelines by biopsy if needed or by imaging, and genetic testing, of course, when needed, and mass spectrometry and biopsy, tissue biopsy for the light chain amyloidosis. And they took all echo parameters done at diagnosis, comparing between different types, and they tried to validate staging system applied already, which I told you about. And they use, of course, the Cox regression for mortality predictor analysis and C statistic to see which add a better prognostic value. And they took at more or less 1 year from the diagnosis the echo parameter. And we know echo is 1 year is a lot already for light chain. So the echo acquisition is as followed. I will not go into details. They calculate mainly stroke volume and all the other parameters that I showed you. And they put the light staging according to the troponin, the Mayo Clinic staging, and the ATTR staging using the one for the NAC in London. And they look at the all-cause mortality. And 1 second, I want just to decrease my here to see if I can make it here. Yeah. So basically, you can see this is the central illustration, the overall mortality, but I will go further later on. So basically, the clinical characteristic according to the amyloid type on this article, you can see we have 600 wild type, 200 hereditary, and more than 1,000. 57% of the cohort was light type. They have a lot of light chain amyloidosis types. And basically, to summarize all this graphics, we have the wild type were significantly older, more often male, which we know already, lower proBNP and troponin according to the regarding the other, with more often hypertension, diabetes, coronary artery disease, dyslipidemia, atrial fibrillation, and chronic kidney disease. Because we know they are older, you can see almost 12 years older, 77 years versus 62 for the light chain, and 65 for the hereditary one. So the second part is the echo characteristic according to the Mayo Clinic, and you can see almost all of the parameters were significantly different between the different types, the light chain, wild type, and the hereditary one. And I will summarize here with you, showing basically that as comparing to the light chain, the wild type one and the ATTR one has a significantly higher LV mass, lower ejection fraction, 51 versus 57, lower stroke volume index. They look at the stroke volume as between 30 to 32 milliliter per meter square, and they took 35 because we know the 35 already these numbers. Worse LV global longitudinal strain and greater apical to basal strain ratio, which was different from the study from 2014. In the wild type specifically, they had higher left atrial volume index, and they thought that it was not related to the pathophysiology of the disease just because of the chronicity of the feeling pressure, more frequent association with aortic stenosis, which already we know already 7% versus 2%, and more RV enlargement and more RV dysfunction. And what was different also that light chain amyloidosis distinctly had more pericardial effusion, 24 versus 11 to 12, whereas the paper from Rapid showed equally pericardial effusion, which is, I thought it was a signature of the disease itself and the burden of the severity of the disease. So remember, higher mass, higher atrial volume, less pericardial effusion for the ATTR, and more LV and RV dysfunction, just because it was more chronic over the time, but we can discuss it later also. Now, regarding the prognostic factor, I showed you this curves earlier, and you can see, and the difference of these curves leads earlier at the first 2 years. When you looked at the 2 years, the light chain had the highest early mortality, 64. And this is exactly what I told you. If you don't need to treat earlier, patient may die within 6 months. So really, really, we need to find this diagnosis very fast, because they may respond to chemotherapy very fast, especially the new molecules that we have, the DARA and all this new B-specific, all this new treatment for the multiple myeloma. It works very well on this patient. Once it responds, the early response means better outcome. So the wild type, they have 77 mortality at 2 years versus 80% for the hereditary one. In the paper of Rapid, the hereditary one has the best survival, which is strange. Here it looks like the same as a wild type. So we need to figure out this one. So the key findings, we have 48 deaths during the median follow-up. So it means if almost we lost 50% of the population of the patient cohort after 2 years, and exactly what happens in King Faisal Hospital here. We lost almost 50% after 2 years. Light chain has worse survival in the first 2 years, as I told you, but after that, survival curves converge over long-term follow-up, suggesting that light chain survivors have good hematological response, may do better later. And this is really confirmed in real life. The staging validation, the higher stage has worse mortality in both light chain and ATTR, and this is already known. And the C statistic was 0.72 for the light chain at 1 year and 0.67 for ATTR. Now let's see what happens when you add the echo parameter of this staging. So what were the predictors? They did a univariate analysis and multivariate, and they found that the independent predictor in light chain were the stroke volume index and the RBS systolic velocity, the age, and the female sex. So they put this in a univariate model, or they took all the parameters that were univariately significant and they put them onto multivariate models. And look what happens when they apply it for the light chain staging and they add the stroke volume. Actually, only the stroke volume improved the C statistic, means the power of predicting the prognosis by 0.04. It's made nothing, but it's maybe 3 points or 4 points, but it was significant, going from 0.72 to 0.75. And they identify that the patient with stroke volume less than 30 to 35 ml, identify high-risk patient. And the stroke volume, we know already about it. It's very simple, reproducible measurement, and every echo, single echo, should have the stroke volume index calculated to patient. So when they put this, you can see that you can able it even further to stratify patient into worse prognosis, the one who has this scoring, the stroke volume lower than 35. Now, they did the same thing for the ATTR beyond NAC, the National Amyloidosis Prognostic System. And you can see again, the stroke volume index was significantly independently associated with worse survival when it's lower, and in addition to the age. And the incremental value to this staging, that stroke volume less than 35 improves statistics, C statistic by 0.3, again, showing you that you can again further stratify patient and more. So the conclusion is that stroke volume can enhance current staging system, may help identify patient needing intensive monitoring and potential target for AI machine learning diagnostic tool. They said that the limitation that have pre-2020 cohort before new therapy, so it may have some bias for this patient. We need prospective validation of these prognostic models, and they did not include the hematological response data that may have influenced the prognostic or the prognosis of the patient. So with that, I would lead, maybe, I'm sorry, I took maybe more time than time. Sorry, Dr. Firas, we can go to the discussion and the question. Thank you.
No, that was absolutely fantastic, Dania. Thank you so much. You covered so much ground in the allotted time. So let's take a couple of questions. I have a couple of comments. The first comment is on the diagnostic side. I know we always try to use the imaging to decide whether it is AL, guess whether it's AL, guess whether it's ATTR. But do you believe that at any point in time we will rely only on imaging to make a diagnosis of AL versus ATTR, or will we always need tissue to make the diagnosis, especially that the stakes for the treatment are so high? You're going to start somebody on chemotherapy with other agents. What are your thoughts?
Thank you, Dr. Firas. This is a very good question, actually, and we are facing this every single day with the fellows who are telling us. So basically, I use myself the echo as a screening tools. So the sensitivity is the sensitivity is good. However, the specificity is not good. So basically, we can use it, yes, to guess that or to screen the patient. Now, regarding your specific question about light chain versus ATTR, if I see a patient that has 22 millimeter of septum thickness, and the patient is walking around and he's like kind of I say less sick. He looks less sick than the guy who's coming with 12 millimeter of thickness. Yes, this is giving me a clue that this patient may have ATTR and this patient may have light chain. Now, how can I use? I showed you the two images. Most of our cases now, I'm not saying all the time, but most of our cases are coming at advanced stage. So most of the patient will come with ATTR with advanced stage. Maybe later in 2 years we'll change our discussion and we'll talk about something else. Patient coming at early stage and they will look like the light chain. So I use it as a screening, but you're right. We have to use the biomarker, and most of the time the biomarker like the NT-proBNP will go very, very higher, significantly higher on the light chain when they present as comparing to the ATTR. The tissue biopsy will need it in all cases when we need to start chemotherapy. When it comes to our mind and we need to know really if this patient has light chain, we cannot be sufficient with the imaging and the biomarker. We need to do either rectal biopsy or fat biopsy or both, or salivary gland. This is the practice.
Fair enough. Dr. Singh, any comments, any thoughts on this piece in particular?
Yeah, well, thank you so much. That's a great question. That was a great presentation, Dr. Moti. So, I would agree with her that there are certain characteristics on echocardiography, including spectral tracking imaging. And then similarly, we talk about cardiac MRI with T1 mapping and ECV, that certain late gadolinium enhancement patterns suggest more light chain like diffuse subendocardial versus transmural patchy, which is there in more ATTR CM. At this time, even with the large meta-analysis with the Gilmore paper, we're realizing that even if we choose molecular imaging, which is cardiac scintigraphy with bone avid radio tracers, in the absence of light chain amyloidosis, the diagnostic accuracy is not 100%. It's very high, but it's not 100%. And then, we'll go through in my talk as well. Why is that so? And then in some patients, the imaging may not be as obvious or conclusive. So in a current amyloid program, if you gather a bunch of experts, we still resort to endomyocardial biopsy to differentiate between, to find out if it's amyloid or not, and then to type the kind of amyloid in about like 5 to 10% of people. For light chain amyloid, we still do 100% histopathology-based diagnosis from end organ, which may include the heart, but like you said, we start with more peripheral sites. Now, however, I think where there is promise, but more has to be known from randomized control trials, is PET molecular imaging. And the reason for that is, now there are PET radio tracers. The most recent, which is in the phase 3 trial, which is a pan-amyloid radio tracers, is the I-124 evuzametide with the REVEAL PET-3 study, that is FDA fast-tracked. With those, I think time will tell if they do prove to be truly diagnostic and prognostic, and we're able to follow response to therapy with those radio tracers, then yes, maybe in the future, once more prognostic control data is available, then we may be able to diagnose ATTR versus AL and then amyloid, yes or no, and even like lesser common forms of amyloidosis, because these radio tracers, they bind specifically to the beta pleated structure of the amyloid, unlike the technetium 99M radio tracers. So I think at this time, for light chain amyloid, we definitely rely on endomyocardial biopsy, and a vast majority of patients for ATTR, we depend on the imaging diagnostic pathway. But in the future, I think with quantifiable amyloid-specific PET radio tracers, we may reach a point that we may be able to diagnose and follow response to therapy non-invasively. So that's very exciting for the field of molecular nuclear imaging.
Excellent. So that was a very nice segue Vasvi to the second part of our presentation, where we'll talk about updates in nuclear imaging for the diagnosis of ATTR and cardiac amyloidosis in general. So thank you so much, Dania, and we'll switch gears now and go to the second presenter, who is a woman of many hats. She, in addition to directing the Cardiac Amyloidosis Center at Midwest Heart and Vascular Specialists in Kansas City, she also is the program director for the Imaging Fellowship. She co-directs the PET and CT programs, and she is a master of all kinds of imaging modalities. So, Dr. Singh, why don't you give us an update about nuclear imaging for diagnosis of cardiac amyloidosis?
Well, thank you so much for the kind invitation, and thank you for the kind introduction. So, these are my disclosures. So I chose a review article, that I had the opportunity to contribute to recently. We published it in JACC CV Imaging. And then that kind of reviews the last decade in cardiac amyloidosis with a focus in imaging. And then for today's talk, we're going to focus on nuclear imaging. But truly, one thing to realize is that we have this opportunity of a very important cause of heart failure, as we are realizing cardiac amyloidosis is not just underprevalent, it's truly underdiagnosed, but a disease state that follows an advanced imaging diagnostic pathway. And therefore, many imagers are actually treaters in the space of cardiac amyloidosis. And then if you look at this patient example here, a central illustration that's showing you, as we discussed, so many echo features that may suggest this is cardiac amyloidosis, including speckle tracking echocardiography or strain imaging, where we talk about the cherry on top pattern. And then cardiac scintigraphy with bone avid radio tracers, and we'll have more discussion about that. Then the role of PET imaging is also, in the works at this time. Currently, there are no FDA-approved radio tracers for cardiac amyloid imaging, but that may change in the next few years to come. And then we spoke about like cardiac MRI. So this is truly a disease that heavily relies on multimodality advanced cardiac imaging. And then the beauty of it is that a vast majority of the patients at this time can be diagnosed with ATTR CM with high diagnostic accuracy non-invasively, which is very different compared to, for example, 10 years ago, when the only way to diagnose even ATTR CM was to do an endomyocardial biopsy and look at histopathology under the microscope. And this is the CMR images. So like similarly, as you saw with Dr. Moti, how the echo morphological features, they transition or increase in phases from subclinical disease to actually advanced disease. This is kind of showing the natural progression of disease in cardiac MRI in a patient with cardiac amyloidosis not undergoing treatment. But gradually what happens is that if you look at the cine images on top, that the LV and the RV wall thickness, including the atrial wall thickness, they keep increasing. The late gadolinium enhancement, it really typically starts what we say in the basal septum or diffuse subendocardial, then it becomes more patchy and then more transmural. And then the extracellular volume typically increases substantially as well. And then what combination you find on a cardiac MRI, which is truly morphological imaging with tissue characterization, it depends on the stage of the disease. Typically, ECV starts elevating, then LGE appears, then ECV elevates more, and then the LGE is even more prevalent. But the pattern of late gadolinium enhancement or the cutoff value of ECV, which is commonly utilized as 40% to be diagnostic for amyloid compared to other phenocopies of increased LV wall thickness, it cannot differentiate if this is light chain versus ATTR or another form of amyloid. And therefore, the role of cardiac scintigraphy with bone avid radio tracers. So the ones that are used in the US, we use technetium 99M, PYP, and HDP. In Europe, and DPD is also used. And then, as you all may know, that these bone avid radio tracers, they were used previously in acute myocardial infarction imaging a few decades ago. And that's because, they go and bind to the myocardium where there's an acute MI, so within the first 4 to 6 weeks period. So that is also one of the causes of false positive PYP or HTP scans. However, as amyloid came into the forefront, because of disease modifying therapy, these radiotracers actually found a repurposed role. And what they find is that these radiotracers have a very high affinity towards amyloid hordes. Up to like almost 40% of even light chain patients, they have some form of PYP or HTP uptake on when you do PYP or HTP imaging. And therefore, when you follow the diagnostic pathway to diagnose ATTR CM, you have to rule out light chain amyloid. Usually the uptake in light chain amyloid is low grade. However, high grade, even grade 2, grade 3, has been described uncommonly in light chain amyloidosis. Nobody knows the exact mechanism of action of these radiotracers, but a hypothesis is that they go and bind to microcalcifications, which are more prevalent in an amyloid horde compared to other radiotracers. No, if we look at this, there's a consensus recommendation on how to do semi-quantitative diagnosis of these radiotracers. So if you look at the picture above, it is an anteroposterior planar image, a coronal section. And then grade 0 is essentially you're saying that there's no cardiac uptake. And then SPECT imaging is so important to know whether the uptake that you're seeing, it's really blood pool imaging, or is it really blood pool versus true myocardial uptake. So you see the SPECT images kind of on top, and then at the bottom, you're seeing SPECT CT images. If within your system, you have a SPECT CT scanner, then it's preferred over a SPECT scanner. And the reason for that is even you are easily able to differentiate cases where there is a lot of blood pool activity that is left because of the radiotracer, but then also early cardiac amyloidosis, where we typically think it starts in the basal septum, such as is shown in this grade 1 case. It can be so much better seen if you have a SPECT CT. It doesn't mean that you cannot do imaging if you just have a SPECT scanner, but if you have a SPECT CT, that's so much preferred, and it increases reader confidence and accuracy, as has been shown. So grade 1 uptake is that where you see some uptake in the myocardium, as shown over here, more towards like the septum, maybe some in the inferior wall, but it's still less than that in the rib uptake. Now, grade 2 is it's avidly positive. You can see it's almost diffuse uptake, and then it is equal to kind of what is there in the rib uptake. And then grade 3 is when there is almost diffuse uptake, which is much more avid or hot than the rib uptake. Now, grade 2 and 3 are definitely positive. Grade 0 is negative, PYP HTP scan. Grade 1, at this time, we realize that any focal uptake is abnormal and it warrants further investigation. So meaning you may end up doing a cardiac MRI with ECV late gadolinium enhancement, and endomyocardial biopsy or biopsy of other organs of the body to establish what is going on here. And a few genetic mutations, that are known to be PYP and HTP negative. So that is something to understand, that there have been cases described that despite having heart failure symptoms, CMR positive, typical echocardiography features, certain like genetic mutations like serine 177 tyrosine 114 cysteine, and others, they may be negative on PYP HTP scintigraphy. And therefore, the diagnostic accuracy is not 100%. However, it's pretty high. So this is the diagnostic pathway that, a lot of you are familiar with, but essentially in a patient that you clinically suspect with cardiac amyloidosis because of the signs and symptoms, and there are echo and or MRI features, as were described earlier, that are suggesting amyloid. And if you find grade 2 or 3 myocardial uptake on on cardiac scintigraphy with bone avid radiotracers, and you rule out light chain amyloid, because remember we discussed the most common cause of false positive cardiac scintigraphy uptake for ATTR is light chain amyloid. So you rule it out with serum and urine immunofixation and serum-free light chains. Those are the 3 tests that are recommended. One-time urine sample, and then one-time a non-fasting blood sample. If this is negative, then you diagnose ATTR cardiac amyloidosis with high diagnostic accuracy without obviating the need of endomyocardial biopsy. So one of the figures that we published in this review paper were just talking about how important it is to not rely on just planar scans. So if you look at top here, this is AP planar image. And if we look at it, the HCl ratio is like 1.5, which by traditional criteria, it's like kind of like borderline positive, and then you're like, okay. But then if you look at the SPECT images, then this is all blood pool. And these are not SPECT CT scans. So you can see, however, still you're able to tell that there is blood pool activity, and this is not uptake in the LV myocardium. Now, this same patient, the first scan is the technetium 99M P/P scan. So this same patient was brought back to the lab, and actually HDP imaging was performed. And you can see that the radio tracer kind of disappears, and then the HCl ratio is actually negative. So there have been different studies, including one that we published, that there's no way, including like left atrial volume index, LVEF, LVDP, that you can predict who will have radio tracer uptake or residual blood pool uptake of the radio tracer compared to who will not. So you have to do SPECT imaging in everybody. And then on our personal experience in other people, we have just seen that HDP may be prone to less blood pool activity due to faster pharmacokinetics compared to PYP. But if you have a doubt, use a SPECT CT system, or in certain cases that are ambiguous, you may be resorting to other alternative techniques. Now, switching gears a little bit to PET radio tracer imaging, as we reviewed in this study, and this was a review that we published in JNC a few years back, just to summarize that really the evidence for amyloid PET radio tracers is accumulating. So here we summarize the studies for C11 PIB, and then there are 3 F18 based radio tracers like F18 flow-beta-PIR, float-beta-PIN, and flute-meta-mol that have been utilized within the ATTR space. What has been seen typically that the fluorinated or the F18 radio tracers do have a higher affinity towards light chain amyloid. So that is just something to think about. And then the most recent radio tracer that has been gaining attention is the I-124 abusamotide, as shown on the bottom here. And then, it does have a technetium 99M ligated form as well that is under research investigations. But you can see like on top, this is a patient with light chain amyloidosis that has a very positive F18 flow-beta-PIR scan. You can see diffuse uptake in like the sagittal coronal and then the axial views. And then these patients sometimes were actually negative by cardiac MRI and PYP or HDP scintigraphy. So that is very interesting to see. But what has been seen in I-124 abusamotide is that it is a pan-amyloid radio tracer, meaning it binds to ATTR as well as light chain amyloid. And you can also see uptake in other organs. For example, you may be able to comment on the liver, the kidneys, as well as the spleen. So looking at systemic amyloidosis with the same scan in addition to cardiac amyloidosis. And then that is FDA fast tracked at this time. And then the phase 3 trial, which is out of Brigham, called Reveal PET study is there as well. So I think, the advantage of PET radio tracers compared to, for example, SPECT radio tracers is that they're more quantifiable. Unless you're using a SPECT CT system, you can quantify it to some extent on SPECT as well. But however, the PET radio tracers, as you know, with the SPECT CT system, you can quantify them. The two big loopholes or blind spots in amyloid imaging at this time is diagnosis early and then following response to or lack of response to therapy. And then those questions in the future may be answered by PET radio tracers, as many of these patients were negative on traditional SPECT imaging because of the higher sensitivity of PET imaging per se, but then also higher affinity and specific binding properties of these radio tracers to amyloid fibrils. But then also because you're able to quantify and look at amyloid, just like we do in theranostics. In oncology imaging, we follow the tumor burden directly as we see it on PET scans, serial PET scans. We may be able to do that in the future with amyloid imaging as well, and that may help us determine if a patient is responding or not responding to therapy, because at this time we rely heavily on clinical biomarkers for that. So I'll leave you with that thought, and with that, I'll say thank you, and we can address questions.
Thank you so much. That was an incredible overview, Vasvi. Thank you. Let me pick up where you left at the end. I think one of the best things that happened in the field of ATTR was the, like you said, repurposing of the bone avid tracers for the diagnosis of ATTR cardiomyopathy, and definitely has facilitated a non-biopsy diagnosis, made it easy to identify patients, made it easy to enroll them into clinical trials, and now we have 3, perhaps 4 approved agents. However, we all know that these SPECT tracers are imperfect. They have issues, and the solution may be in going into a PET tracer. So the question is, as somebody who practices outside of the United States and North America, we already have issues with access to PET, let alone the tracers, access to the hardware. If you were to look down the line, how do you see the access versus diagnostic performance balance out in a way that we want a reliable tracer, we want it to have access to it though? What are your thoughts?
Yeah, that's a very insightful question. Great question. So I think, one of the ways to learn about what may happen on like a SPECT plus minus PET versus SPECT versus PET in the amyloid space is similar to myocardial perfusion imaging, because now we know that, PET with its quantifiable myocardial blood flow, we know is superior to SPECT imaging. However, a majority of places where we perform stress tests or myocardial perfusion imaging are still utilizing SPECT. And that is because of the reason that you mentioned, is that PET is very, the equipment, the personnel, if you invest in a rubidium generator, are you close to a cyclotron? Do you have access to Florcato, which is like the recent thing? These are very factor limiting, and not a majority of the places, they do not have that much funding available or resources available to have that present for every stress test, even though we know that in patients who cannot exercise, it is a superior modality. You can tell epicardial coronary stenosis, the negative predictive value is close to 100%, that you don't miss balanced ischemia. You go ahead and can diagnose microvascular disease. So I think a similar trend will be available towards amyloid, in my opinion, and that because despite being data available on PET myocardial blood flow, the resources unfortunately restrict its utilization despite knowing clinical relevance and importance. The way it might end up happening, however, I still feel like having data on PET myocardial blood flow is so important. It's so prognostic. It increases our insight into the disease and understand pathophysiology. And I think that's how the amyloid PET radio tracers would be too, that it would be great to know which patients are responding, not responding, are we able to diagnose it? And then patients, may travel to a tertiary site who have these resources to get a one-time diagnosis. However, a majority of the patients will still be preliminary diagnosed by PYP imaging, just because SPECT is so much more ubiquitous compared to PET. So I think it will be kind of like a hybrid model that we follow in perfusion imaging also, because resource limitation is a very true real world problem everywhere. Even in the US, that the density of PET radio tracers is so much less compared to SPECT, and then therefore, and then the radio tracer availability will be a whole different question, and that will depend on the pricing, their travel time. The good news is, the I-124 F18, they have longer half-lives compared to like rubidium, for example, and ammonia. So I think delivery from radio pharmacies may be, more feasible. However, the equipment and then the technologists would be a challenge, just like for perfusion imaging. So that's a great question.
So what I hear is SPECT will continue to be the workhorse in select cases, equivocal scans, etc. You will use PET. or if you want to look for response to therapy or staging or something along these lines.
Yeah.
Excellent. Dr. Dania, if you're still with us, I have a question from the audience. One of the audience, my question is very simple. Do you personally believe that imaging is going to fully replace endomyocardial biopsy in diagnosing ATTR cardiomyopathy in the coming future? What are your thoughts, Dania?
Sorry,
Do you think imaging will fully replace endomyocardial biopsy for diagnosis of ATTR cardiomyopathy?
Actually, it's already replacing, because you have, as you can see, that since Gilmore said in 2016 that no need cardiac biopsy doing, and Dr. Singh said that it's only in 5 to 10% in some difficult cases we go and we have access to the endomyocardial biopsy, but in 90% of the case we have already the diagnosis with ATTR with multimodality imaging, especially the scintigraphy of the heart, the bone scintigraphy of the heart with the PYP or DPD or whatever tracer you have. And if it's grade 2 and 3, and you have a no light chain criteria by you rule out monoclonal gammopathy, you have the diagnosis. You don't need to do a myocardial biopsy.
And I totally agree with you. Data from Colombia has shown that the number of PYP scans has surpassed the number of endomyocardial biopsies. Recently, data from THEOS registry, which is real world, also showed that the number of diagnoses based on PYP, DPD has also exceeded the endomyocardial biopsy. So I think the first line is going to be imaging, but there are still select cases where you want and can perform biopsy. We have a couple of minutes. Dr. Singh, how do you deal with scans that have some uptake? Not the grade 2 or grade 3 that Gilmore used to define ATTR cardiomyopathy, but it is there. So question number one, do you call it a grade 1, 2, 3 or something, or do you call it equivocal? And number two, what is in your mind? Is this an early case of ATTR? How do you follow up these patients? What are your thoughts?
Yeah, that's a great question. So in terms of like reporting, what is encouraged at this time is that, you know, it is better to shy away from the term equivocal. Just the reason for that is, you know, you want to give a clear action plan to the physician who you're reporting to, who will be a recipient of your report. And equivocal, it doesn't mean was it like a technical problem? You know, was it like an artifact? You know, did the radio tracer infiltrate? You know, does the patient need to come back? Is it like, are you calling it false negative? Are you calling it false positive? So I think the way it is recommended at this time, just describe exactly what you're seeing. So for the reporting perspective, if I see that there is a focal uptake of the radio tracer in the basal septum, that is exactly what I say, that there is grade 1 uptake of technetium 99M radio tracer as seen on your septum. And then I say would recommend further diagnostic evaluation. And then at least that tells the people that, okay, yes, they did see uptake. They're not talking about radio tracer. The patient does not need to come back for another scan. They need further investigation to tease out what it is. And then because we know, like there are papers out there that have described that there are different kinds of positive uptake of PYP, and that can be focal, it can be patchy, or it can be patchy on diffuse or completely diffuse. So the thought process that we have that it has to be diffuse and ubiquitous in the LV, that has fallen out of favor. Any avid uptake within the radio tracer in the absence of an acute myocardial infarction, you know, is considered abnormal and warrants further investigation. So the second part of the question, what do you do next? I think a lot depends on the patient. So within the past year, I've had like 2 patients who were TATA mutation positive. Okay, so I know that they have a mutation that is very likely going to get a cardiac phenotype, because that's a mutation with like, you know, perfect mixed phenotype between neuropathy and cardiomyopathy. And then the penetrance is more than 90%. So, and then their age group was in the 50 to 60% range. So in those patients, and then both of those patients had septal uptake. So I do get a cardiac MRI, and they did have ECV that was elevated in that region. And then in one of those patients, I started with doing a fat pad biopsy that was positive. So if you have TATA mutations, you have clinical features, the PYP scan is focal positive, and your biopsy is fat pad positive, that's very convincing that this is amyloid, and then you go ahead and treat them because they're already in heart failure. The other patient, actually, I tried to do a fat pad biopsy because, the yield for hereditary ATTR is still in the 30–40% range. It's not as good. The yield for fat pad biopsy is best for light chain, and then it's for hereditary, and it's really dismal in the around 20% range for wild type ATTR. So for the other patient, we did try fat pad biopsy. It was negative. They did not have kidney or any other involvement. So we actually ended up doing an endomyocardial biopsy because the uptake is in the basal septum. And then the beauty about endomyocardial biopsy with amyloid compared to sarcoid is that it does have a very high negative predictive value. Like if the biopsy is done right and if it's negative, the patient does not have the disease. It's not that you're missing disease. So the other patient, we did an endomyocardial biopsy and it was positive. So they were started on treatment as well. So the way I do it is that I absolutely make sure that I have other correlative imaging. If they can have MRI, then I do that. And then I pursue some form of biopsy, because if they're clinically symptomatic and I'm seeing some focal uptake, then we want to make sure that we exhaust resources so that we can start treatment early. Now, if the patient was completely asymptomatic and this was like a carrier state, for example, somebody else who's like they're 35 years old, the family has, for example, T60A or even a less penetrating mutation, like for example, if you have V142I, then we know only 33% of patients who have the mutation will actually get the disease. And if they're completely asymptomatic, we did I do NT-proBNP, high sensitivity troponin, echo with strain, all of that is negative, but they just had incidental PYP uptake. Then, the expert recommendation is you repeat it every 2 years or 2 to 3 years. However, you follow them clinically every year to see how they're doing. The recommendation for cardiac MRI, if that is what you were following, is every kind of 4 to 5 years, just because it's a more intensive modality, there are more resources involved. But a lot will be dictated by their family history, what age they are compared to the first patient that was diagnosed with the disease in their family, what kind of a mutation it has, how much is the penetration of that particular mutation compared to others, and then how are they doing clinically is how I would approach it.
Excellent. Dr. Dani, any final comments, any final thoughts?
Actually, I was seeing the question on the panel here. One of the people asked a very nice, very good question. I mean, should I refer everyone to the PYP, or we have any screening feature that should we send all the AS population? So for the final thought is that we should not screen everybody, but Dr. Singh said we need some red flags, either clinical, either echo, either biomarkers, or all of them. So if you have any red flags, especially in male that are more than 70 years, and you have unexplained LVH, unexplained heart failure with somebody who is otherwise clinically healthy, yes, you can go for screening for this patient. So you don't have to screen everyone, but some really with the red flag, especially if someone has low flow, low grade aortic stenosis, unexpected higher proBNP for the level of the aortic stenosis, and higher pulmonary hypertension or RV dysfunction. Just to make it shorter, because
more rational referral and screening rather than a gunshot approach.
Yeah.
Fantastic. It is 3 minutes past the hour. Time went by so quickly. This has been a very insightful discussion. I would like to personally thank each one of you, Dr. Dania Moti from King Faisal in Saudi Arabia, and Dr. Vasvi Singh from Kansas City for number one, your time, and number two, for your in-depth input on this subject. Thank you so much. And this will bring this session to an end, but the Gulf Amyloidosis Club will continue. We'll be back with you all next month, and we'll bring new experts and new articles and new insights. Until then, I would like to leave you with goodbye, and we'll be back in touch. Thank you so much.
All right, thank you.
Thanks all.